chairpersons, respected reporters and learned audience, good noon. My topic today is problems and pitfalls in the management of asthma in the community. I welcome you all to this session. I would like to dedicate this presentation to the memory of my respected teacher, once famous professor, a great clinician who used to rely mostly on clinical grounds, used to discourage too much dependence on laboratory, devoted himself in a methodical teaching, whom we should follow today, that late Professor S.G.M. Chaudhary, FRCP, peace be upon him. Problems and pitfalls in the management of asthma in our community. There are various problems, and we can categorize mainly them into diagnostic and therapeutic problems. Diagnostic problems, asthma is mostly underdiagnosed, and therapeutic problems are various. We will be coming to the discussion. There are some scientific limitations also, because there is no guaranteed cure. And regarding awareness, there is lacking in awareness in the community. And literacy problem is very high illiteracy in this country. Superstitions or dogma are present in our society. Financial problems, around 38% of our people live below poverty lines. And healthcare delivery system, doctors are not available in the remote areas. So in broad heading, these are the problems we face to manage asthma in the community. Asthma is one of the diseases longest recognized as distinct entity. It has moved to center stage as a public health problem in the last 30 years. Asthma is now recognized as a common cause of disability, of great economic cost, and of preventable deaths. How common is asthma in adults and children? Do we diagnose asthma rightly when the patient presents to us? Do we serve standard prescription when we diagnose asthma? Do we teach the patient regarding his disease, medication, and is part of precaution to be taken to prevent exacerbation? Do the patients comply with the doctor's advice? The first NEPS study in 1999 showed that 5.2% of the population suffer from asthma. In that respect, we have about 83 lakh out of 16 crore people. And more than 50% of these patients are children. That is around 40 lakh. 7.4% of the total pediatric population of 1 to 15 age group suffer from asthma. And more than 90% of this asthma do not get modern treatment. The disease causes physical, psychological, and financial suffering, work and social absenteeism, and overall negative socio-economic growth and productivity. Though mortality from asthma is few, nevertheless, significant number of patients die every year, and 80% of this death can be prevented. Regarding the diagnostic problem, no definition of asthma is universally accepted. Attempts to define asthma has been reversible airway obstruction as an inflammatory disorder with cough, shortness of breath, chest tightness and wheeze, and bronchial hyperresponsiveness. But this is a very descriptive definition rather than an etiologic one. And National Heart, Lung and Blood Institute of US in 1995 accepted ZINA, who is defined asthma as an inflammatory airway with many cellular involvements and recurrent episodes of wheezing, chest tightness, shortness of breath, cough, associated with widespread airflow, variable airflow obstruction, increased bronchial hyperresponsiveness, and also subbasement membrane fibrosis. So this is a very long definition to define asthma. So here needs to define asthma in a very precise manner so that any clinician can define it easily and diagnose it easily. No feature is unique to asthma, and no feature is universal in those with the condition. For example, all tests of airway caliber may be normal between attacks, even in patients whose attacks are sudden and severe. Cough occasionally is the only symptom of asthma. If the physician considers asthma as a diagnosis, it is not much difficult to establish it. So it will have to be suspected. Bronchial responsiveness may be normal over most of the months in a year in seasonal asthma. And bronchial hyperresponsiveness is often found in people with allergic rhinitis but without asthma. Even the association of eosinophilic bronchial inflammation and asthma is inconstant. Daily fluctuations, predominantly nocturnal symptoms, may be associated with uncontrolled GERD, sinusitis, and pharyngeal dysfunction. Fluctuation can also be precipitated by exertion and exposure to a variety of environmental agents, including cold air, dry air, oxidant, pollutant, tobacco smoke, perfumes, dust, and many things. Physical findings of asthma correlate poorly with more objective measures of airway obstruction, such as pulmonary function tests. Nevertheless, the clinical findings are useful, and in most cases, asthma can be diagnosed clinically. Some patients with recurrent episodes of wheezing and dyspnea associated with reversible airflow obstruction and bronchial hyperresponsiveness have no evidence of eosinophilic inflammation in bronchial biopsies. Other patients have eosinophilic inflammations of the bronchial mucosa and chronic cough that is responsive to treatment with an inhaled corticosteroid but have neither airflow obstruction nor bronchial hyperresponsiveness. And some patients with severe asthma have predominance of neutrophils, not eosinophils, in their bronchial mucosa. Despite all these shortcomings, the limitations of descriptive definition, asthma have not proved to be critical. The clinical features of asthma requiring treatment are for the most part easy to recognize, so working definitions have sufficed. Nevertheless, asthma remains underdiagnosed, especially the childhood asthma. Severity assessment is important in selecting treatment step. In an asymptomatic asthmatic patient, physical findings may be absent. However, wheezing may be elicited by forceful expiration. With profound obstruction, wheezes may be heard only during the inspiratory phase and may even be absent with profoundly diminished air movement. A respiratory rate more than 30 breaths per minute and a heart rate more than 120 beats per minute suggests severe bronchospasm. A pulse is greater than 20 mm mercury suggests profound obstruction. With severely lowered breathing, the patient can be diaphoretic, anxious, and unable to speak in full sentences. Hesitation, confusion, somnolence, and cyanosis are foreboding findings and suggest impending respiratory failure and need to mechanical ventilation. Unilateral loss of breath sounds can be consistent with a mucus plugging and secondary atelectasis. But these findings also must raise the possibility of a pneumothorax. So underdiagnosis of asthma is a frequent problem, especially in children who are labeled as asthmatic bronchitis, bronchiolitis, or pneumonia. And recurrent episodes of cough and wheezing are almost always due to asthma in both children and adults. So the key points considering a diagnosis of asthma in childhood are wheezing, especially recurrent. Absence do not exclude a diagnosis. 60 to 80% of childhood asthma get cured or permanent remission if properly diagnosed and treated, in contrast to 20 to 30% in adults. Hence, diagnosis of childhood asthma is rather more important than adults. Some of our physicians and pediatricians are very much miserly to diagnose asthma even when all the cardinal features are present, though they are supposed to have adequate knowledge about it. Asthma is the most common chronic disease in children, although majority remains underdiagnosed. And in most of the cases, they are diagnosed as asthmatic bronchitis, childhood wheeze, cold allergy, chronic cough, allergic problems, sinus problems, recurrent pneumonia, like that. The prevalence, severity, and mortality rate associated with asthma clearly has increased over the last 40 years, despite tremendous advancement in medical science. So the therapeutic problems are also there. More than 90% of asthma patients do not take modern treatment. So what treatment do they take? They take unscientific treatment, homeo treatment, cough syrups, herbal, traditional, or no treatment at all. And many develop iatrogenic Cushing syndrome after taking herbal treatment, no doubt about unscrupulous mixing of steroid. Those who get modern treatment, how many get standard step care management or have their symptoms controlled? Many physicians still avoid inhaler drugs, and even after making a diagnosis of asthma, they prescribe drugs like ketotifen, theophylline, Montelukast, salbutamol or benzoyl tablets and cough syrups and frequent antibiotics in various combinations. So this is the 2006 guidelines of asthma management. We will have to follow these strictly if we want to control asthma. What percentage of asthma? What percentage of physicians to follow this guideline, especially the GPs? It is our responsibility to teach the GPs to orient them to treat asthma according to step care fashion. And some prescribes only reliever inhaler, salbutamol without preventer inhaled corticosteroids, without considering any step in accordance with that severity. Some doctors suggest only nebulization when severe breathlessness without a maintenance therapy. Sometimes selection of a step does not correspond with the severity of the patient. Assessment of severity is very important. Asthma control needs adequate understanding of the disease by the patient, especially regarding the precipitating, aggravating factors. Mere serving a prescription, whatever appropriate it may be, is not enough. So the responsibility of the attending physician is to impart knowledge regarding asthma and to avoid all the precipitating factors, continue to prevent the drugs, to comply with the prescription properly, not to be reluctant to use rescue steroids. And some people believe childhood wheeze is a normal phenomenon and needs no treatment. A very common problem is not to teach the patient how to use the inhaler. Common mistake is not to shake the inhaler. Somebody will be taking the inhaler in an inverse way, I mean the upside down. I have seen patients taking inhaler through nose. Somebody will be inhaling 4 or 5 puffs and keeping it within the oral cavity. So it is not going to the respiratory tract at all, so it will not be effective. So it is the responsibility of the physician who is treating the patient to teach the patient appropriately to how to inhale the inhaler. Patient may not know when the symptoms subside, the patient may give up taking inhalation and he may occasionally take only the reliever because as the effect is immediately observable, he may stop taking inhaled steroid. Rescue steroid therapy should be considered when relevant. Scientific limitations. No single drug is sufficient for asthma control. Combinations of various drugs are needed for treatment of asthma. No guaranteed cure has still be possible, so less acceptance of treatment. Even after giving best combination therapy, some asthma remains refractory. The airways of asthmatics are characterized by mixed inflammatory cells. If it is simply an inflammatory disorder, why are the NSAID drugs, indomethacin and other NSAIDs are effective? So, bronchodilator and anti-inflammatory steroids have become the mainstay of treatment. Occasional patients may have not their severe persistent asthma adequately controlled despite daily systemic steroids. If it is immune-related inflammation, IgE-mediated and allergic asthma, anti-IgE monoclonal antibody omalizumab is being tried, but no lasting remission cure is obtained. Again, ineffective in non-allergic asthma, also IgE is not too high in all asthmatics. Patients with persistent asthma with an inconclusive allergic testing history may undergo skin testing. If there is clear relationship, he may undergo immunotherapy and cytotoxic and immunosuppressive therapy, but hazard must be considered. Sometimes it may be misdiagnosed with COPD, mitral valvular disease, left ventricular failure, tuberculosis and ILD, and concomitant cardiac failure and asthma should be treated cautiously. Elderly asthmatics and COPD patients may also suffer from comorbid conditions like hypertension, diabetes, ischemic heart disease, dyslipidemia, obesity, a metabolic syndrome, osteoporosis and osteoarthritis, and generalized anxiety disorder and depression are very important. So sound knowledge regarding treatment of such condition is essential for the physician. 40 to 60% of asthmatic people have got allergic rhinitis, so that must be also treated. Failure to control the trigger factors. If the asthmatic patients are repeatedly exposed to trigger factors, asthma cannot be controlled. Whenever needed, especially in the children and very old, spacer and nebulizer must be used. Special situations like surgery, pregnancy, exercise-induced asthma, and osteoporosis, everywhere asthma can be treated. So in conclusion, how can we manage and control asthma in more than 10 million people in a country like ours, where 38% of our people live below poverty line? Fortunately, not all asthmatics are severe, and more than 90% of asthmatics can be managed in their homes. A monthly expenditure of Bangladeshi Dhaka 500 to 1,000 is enough for asthma treatment in the majority of cases. What I believe, only cardiologist cannot manage to control hypertension. Only endocrinologist cannot manage to control diabetes mellitus. Of a population more than 16 crore. Similarly, only chest physician might be around 100 cannot manage to control asthma of the same population. It is a great loss of productivity and career build-up, the value of which cannot be calculated in any amount. So every medical graduate should know the standard treatment of asthma, and Asthma Association Bangladesh can take the responsibility to orient all medical graduates. Thank you very much for your